solution with the plasma solution. And these are the Botox injection needle what we use for hysteroscopy. So this goes through 5' channel, operative channel, and so we use this Botox injection into the bladder. So that is how we are well versed with injecting with the Botox injection needle. So we have been injecting Botox into the for interstitial cystitis into the bladder. So that's how makes the procedure easy. So you can see the video of this. It is simple hysteroscopy, 2.8 millimeter. You can see the Botox needle going into the subendometrium. So the needle has to go, it should not go deeper into the myometrium. It should go into the subendometrium, and gently you inject zero point 0.5 to zero point 0.7 ml, so that there is a ballooning of the endometrium. So the ballooning is seen. That means so you are easily depositing the stem cells into the subendometrium. So we inject into all the areas and keeping the vision clear. So during the injection of the stem cells, the vision, hysteroscopic vision has to be clear. Otherwise, you don't know where you are injecting, and all the areas, anterior wall, posterior wall, lateral wall, cornea. So all the areas are equally injected with the stem cells, but little amount of leak and bleeding may happen. So that is fine. So that you can ignore. That little bit of leakage from the injection site can happen, but it doesn't matter. So as long as the solution goes into the subendometrially below the endometrium, so I think we have done the job. So injecting stem cells, so no role of dilatation of the cervix, because it may make the process traumatic. Do not use misoprostol, and don't give any of the pyroxicam, all these things. And so we give atosibon, so that at the end of whatever the solution is remaining inside the cavity, that may remain inside. How do the stem cells improve the endometrial response? So the stem cells stimulate the angiogenesis. That is most important thing. It increases the number of glands. It enhances the thickness of the endometrium area. So it decreases the fibrotic area and better form tissue construction. So the remodeling of the endometrium takes place. So by all these five mechanisms, the endometrial response will improve, so that the thickness of the endometrium will improve and the pregnancies will improve. So in our experience, from September 2019 to February 2020, we did three cases which have been already undergone treatment with various this thing, and two women had aborted in the early weeks of gestation because of, probably because of the thin endometrium or some other cause. And so you can see here, so out of 3 year patient, one patient, the successful one, was a 29-year-old married for 4 years. She had a tuberculosis, and tuberculosis treatment was given. Her hysteroscopy was normal, and she had hydrosalping. Salpingectomy was done. Had undergone IVF cycle in outside, but it was failed because of the thin endometrium, and she was advised surrogate for because of the very thin endometrium, but she refused surrogacy because she wanted to have her own pregnancy. So in our we gave the trial, a FET trial in the first cycle. So we gave Progenova for 15 days, high dose, but we could get maximum endometrium was 6.1. So with that, we couldn't do any transfer. So then we decided for autologous stem cell injection, and we took the consent, and we explained that this is only experimental, and we cannot guarantee you. She accepted. And in the next cycle, so from the second day, we started the HRT, and on day 5, we gave granulocytic stimulating factor. On day 7, is hysteroscopic autologous stem cell. One sitting was done with the from the bone marrow, that is ilia crest, and HRT was continued. And HRT we continued till day 7, when the endometrium became 7.7. So from 6 to it became 7.7. Though it is marginal for the patient, it is significant. So up to 8 point would be better, but we could get 7.7.
Hello.
And two day 3 embryos were transferred, and the patient conceived, and the patient is now 15 weeks singleton pregnancy, and McDonald cervical stitch is done.
Yeah.
Friends, to conclude, stem cell is a very good method, so there is no hesitation, and this therapy gives a very good hope to disorders patient where unsuccessful IVF outcome due to thin endometrium, and in future, so we definitely see more and more stem cells for thin endometrium and Asherman syndrome. Thank you very much for your patient hearing.
Thank you so much, Ramesh sir, for this nice lecture and your new innovation. At the outset, because we were not connected, I would like to welcome all of you to this webinar of KIAGE.
Rihan, can you please share my screen? Mr. Rihan, please share.
Halka and Dr. Sergio, any comments on the stem cells? Any experience?
Sir, we will take it in the end. And when we are doing the questions, we will take it, sir.
Sergio, do you have any experience with any stem cells?
No. I'm helping a group in China that are working on that in the state university, the capital university of Beijing, but I don't have personal experience.
So thank you so much. We are doing this webinar with the association with the Global Community Hysteroscopy.
And I share my screen.
I am thankful to Sergio sir, Dr. Nash, Dr. Corugno for all their support, and Alka ma'am for your scientific coordination. And I welcome Miriam madam also to this program. And it's a great event for us because FOXI, ICOG, and the committees of FOXI are also associated with this. So I welcome the audience. By now we have reached 1,500 registrations. That is really good. I thank everybody who is watching now for their interest in hysteroscopy. And now I think without wasting much time, let us go to the next lecture by none other than, for all we are waiting, sir, Dr. Sergio Gnaneshwari. Please introduce Sergio, sir. And sir, we wanted you for the conference in Bangalore, but now it is a real pleasure for us that you are with us and doing this webinar. It's a great moment for all of us, sir. Thank you so much for accepting our invitation. Gnaneshwari, please introduce Sergio, sir.
Good afternoon, sir.
He needs no introduction. He's very popular in India now.
As ma'am said, sir needs no introduction, but still let me take it as a privilege and a honor to introduce Dr. Sergio to the delegates. Sir has done, as you can see, his PhD in OBG from the University of Barcelona, Spain. He's the head of the hysteroscopy unit in the OBG department in the Del Mar University Hospital of Barcelona, the director of ambulatory surgery and hysteroscopy unit in Israel. He is the director of International School on Laser in Gynecology in Barcelona. He's the chairman of the Global Community on Hysteroscopy. And also it was there also in his CV that he's a visiting professor to the Beijing University in China. Sir, you're truly a very international hysteroscopic person, sir. Over to you. The audience will be eagerly waiting to listen from the expert himself.
Sir, you are really global. Inspired.
Global.
About the global community. You yourself are global.
Thank you very much.
Stop sharing my screen.
Yes, if you give me, I will share mine. It's really a big honor to be here with you again. You know, I love your country and I have coming to your country. It's just a pity with the lockdown that we cannot see each other as we wish, but this is a good way to do it. I was asked to talk about spotlighting office hysteroscopy. I could have done it in a very academical way, but I thought that maybe in a more motivating philosophical way, it should be, I think you will enjoy more. First, I don't have any conflict of interest regarding this presentation. Um, See, look at this picture. This picture is how I saw when I was a trainee my first diagnostic hysteroscopy. You look here on the table and you see Hagar and you see not speculum, but you see many things only to perform office hysteroscopy. Sorry, diagnostic hysteroscopy. And this diagnostic hysteroscopy, of course, was performed in OR under anesthesia. A long way we passed since I saw this diagnostic hysteroscopy until what we do and we perform today. Today we perform diagnostic hysteroscopy in office. In office, actually, it's part of the diagnostic flow of our patients. This is a picture in a reproductive unit, in this case in Bulgaria, but we do the same in my hospital. The patient, she comes to the office, you do the anamnesis, you ask her many questions, and then you perform ultrasound. And if you see anything or you need to see more, you, at the same setup, without moving, without taking the patient to any other place, you start doing diagnostic hysteroscopy. We're dealing with very low diameter scopes, no pain, and that's the way we think and we believe it should be done today. So if you look at the publications, the papers published, this is from PubMed, on office hysteroscopy, look the increase that we have been living from the last 20 years. Every year we increase the number of publications. So I want to transmit to you some what I believe are important ideas regarding hysteroscopy. First, I believe that every gynecologist should know how to perform a diagnostic office hysteroscopy, the same as every urologist know how to perform a cystoscopy. If they perform cystoscopy in office, why cannot we, all of us, perform a diagnostic office hysteroscopy? Right now, we know that around 10 to 15% of all the OBGYNs perform hysteroscopy. It's just the tip of the iceberg of gynecology. We believe that it should be the opposite. Most of us should do diagnostic office hysteroscopy. It's part of a tool that I believe it's by definition a tool of the gynecologist, the hysteroscope. That's why we believe that my hysteroscope is my stethoscope. That's our basic tool. So the first important idea is that everyone should know how to perform an office diagnostic hysteroscopy. We go to the second idea. Our fears, I believe that there are mental walls that we need to break down. What stops us for going forward is what we think, not what really is. And what are our fears that we need to overcome? We always think that it may be painful for the patient if we do it in office and not in OR under anesthesia. Second, we are afraid about dealing with complications in an office. It's not the same in a hospital, in OR. And third, if we want to start doing it by ourselves, maybe it's very expensive regarding what we get back for a diagnostic office hysteroscopy. So let's try to overcome those fears. First, this one, it may be painful for the patient. We know today that modern optics are less than 5 mm. So there is no need to dilation or to use anesthesia, especially in young nulliparous. You may experience in some postmenopausal women that they may feel some discomfort, but even though they may feel that, in time you will get skilled to overcome also this kind of problems. And most of the patients, what they express during our procedure is that they are afraid, they're scared, they express anxiety. And anxiety makes all the experience to be overreacting experience. They feel that something small, they're afraid, and they express it like something big. So there are some techniques, all of them based on distraction, that helps us during this procedure to overcome this difficulty. And we have passive techniques and we have active techniques. The passive technique is to use our nurse or even ourselves doing local vocal verbal anesthesia. We ask the patient, Do you have children? Do you have grandchildren? What are they studying? What are their names? How old they are? And you ask them a lot of nonsense, small questions that makes a distraction. And then we have the second one is the active one. We can ask the patient to do some tasks during the procedure, or what we do, we let them choose music. Right now, you know, I'm working in an hospital also here in Israel. Since the lockdown on March 1st, I couldn't go back to Spain, so I'm locked down here in Israel since March 1st. In our hospital, half of the population are Jewish, and half of the population are Muslims. Both the staff, doctors, nurses, everyone, and the patients. And Muslim patients, I let them choose music, and most of them, they choose to pray. They choose a surah from the Quran, and they pray during the hysteroscopy. And when they start, you know, listening to the surah, they go away to another place, and they are very relaxed. So the music or what they listen to also helps to overcome what you are afraid of, if this pain, that there is no such a thing like pain. And let's go to the other one. How would I be able to deal with complications during office? I'm in an office, not in an hospital. So I ask you, what complications? What are really these? There are no complications in office hysteroscopy. Our mistakes don't limit us. It's our fears that they limit us. When you go in an office hysteroscopy without anesthesia, you know, the moment you touch myometrium, there is a lot of innervation. She will have a lot of pain. So you will never perform a perforation during office hysteroscopy without anesthesia. There are no big, and we are dealing with small diameter scopes. There is no using too much fluids also, overload of fluids. So don't be afraid. The only thing you have to do is just to be gentle, not to be with force, but be gentle and to listen to your patient. And when you listen to the patient and she say, I'm feeling something, so listen and react. And if she say, I'm feeling pressure, so you reduce a little bit and you adapt yourself so you may do it in a comfortable way for your patients. And then we go to the other mental barrier that we have. It's the setup. It might be very expensive. Okay, this is my setup in the hospital, my hospital, then the last one, and the other one in my private clinic. This is for surgery, not for diagnostic. When you go surgery, you know you need a lot of equipment. But when you go for diagnostic hysteroscopy, you need basic, simple equipment. You have even equipment adapted to your laptop. You don't need to buy a screen with high quality. And look, I found this small suitcase that inside has all what you need. It has a scope, Betoculi with, if you need working channel. It has also a camera that is an HD camera that's connected directly to a laptop. You don't need more than that for office hysteroscopy. Light source, everything USB, and even the software, so you can take the picture and it goes directly to the report that you give to the patient. So you can, and the price of that is it's like the price of one scope of a big company. So you can get also non-expensive with high quality equipment that allow you to perform office. I have another important idea. Every journey begins with the first step. And I believe that office hysteroscopy for diagnostic purposes is the same. It's like a baby that starts to walk. You know, at the beginning, it's very hard to stand up. When the baby stands up, the first steps, they fall and stands, falls and stands. And it takes a while until he starts walking in a confident way. And then in time, he will like to start running. The same with hysteroscopy. When you start doing hysteroscopy for diagnostic purposes, it's like a first step to go inside to look. You don't need anything less. And at the beginning, you won't feel confident and you will be very afraid. But every hysteroscopy you perform will give you more self-confidence. And then when you feel confident and you believe in yourself, you will start walking in a fluent way. You will do it without fear and you will be very confident. And then you will see a polyp and you say, what if? And you will start thinking about running. And the moment you take your first gasper and you take out your first polyp, you start to run. And the moment you start to run, the sky is the limit, because you will start with small polyps, and then you go to bigger polyps, and then you will see a small myoma, and then you are going into the next step. You are moving from diagnostic hysteroscopy into surgery. And we deal with what we call the uterine cavity surgery. So we have hysteroscopies, those that go inside only for diagnostic purpose, and we have the surgeons of the uterine cavity. That's the way we see it today. And we have many devices developed for doing endocavitary surgery in office. This, what you see here, the picture, or a small morcellator, manual morcellator that goes through the working channel of the scope, 5 French, and you squeeze it and you morcellate. And you have also mini resectoscope if you want to start. You know how to perform a resectoscopy in OR. So now you have also 5 millimeters resectoscope that will allow you to do office resectoscopy the moment you go to surgery. And in our case, we started to do it with laser. So now in this video, you will see a polyp, not a small polyp. And you will see this is the one polyp. And when we go to the left cornwall area of this uterus, you will see other small polyps. And we use the laser, diode laser. Diode laser is the laser that you use in your remote control on the TV for hair removal. Is the most used laser, is the cheapest laser technology. And the laser cuts and coagulates simultaneously, no bleeding. And it's very fast. And the dispersion of the heat, it's only 0.5 millimeter to 1 millimeter. So it doesn't affect myometrium. No discomfort, no pain. Look how fast it cuts. In a moment, you finish cutting this not so small polyp. And it's real time, it's not edited. So that's something, the moment you start to fly, you may think about starting to use it, but first, you will need to know how to run and start by doing your first steps. This is about doing surgery, but from here, we can go to here. You can start doing, like in this case, a small polyps that with the grasper is the first step. You just take your grasper through the working channel, you grasp, you catch the base of the polyp, and you just push it and you take it out. It's easy, no pain. That's the way to start doing your first steps in surgery. And in the second video, you will see more complex surgery, in this case for fibroids, for myomas. At the beginning, we use MyoSure. MyoSure is a morcellator for it's a tissue removal system. So as you see, it's removing all the tissue from the myoma out, and it works in a pretty good and fast way. There are different kind of morcellators from different companies, and all of them work very well. And it's a way to do it in an easy, to do surgery without having to pass through a very difficult learning curve. It's a short learning curve to use this kind of devices the moment you know how to move inside the cavity. This is the use of the mini resectoscope. This is from Jaime Ferro from Valencia, from the IBI Valencia. Look at this. This is a fibroid that's almost a type 3. It's very deep fibroid inside the wall. Only this small distortion of the cavity. So first he takes out the endometrium and he looks for the myoma. And the moment he looks for a myoma, he tries to find the limit of the myoma, what we call the cleavage plane, the pseudocapsule. That's the area that is between the myoma and the uterine wall, the myometrium. And you make the dissection to alleviate the myoma from this pseudocapsule. And that's what he's doing here in this procedure. And this procedure is with 5 millimeters resectoscope. It's performed in office. What I'm showing you now is office techniques. And he's taking slides the same as in OR with the big resectoscope. I think it's the natural way from going from OR to office, to use the tool you are trained and used to use in your everyday practice. And what he's doing is trying to disattach the fibroid. So he's cutting and disattaching, cutting and disattaching from the myometrium, always respecting this plane where the pseudocapsule is. He's pulling the myoma, taking it out, pulling, and you see the limit behind there. And I want you to see at the end, there is just the fovea where the myoma was, and you see the pink color of the tissue where the myometrium is. So no, you don't do scars in the myometrium. The probability of having adhesions or affecting the fertility of the patient is very low by using this technique. And now he's just finishing. Look, he's disattaching it, not touching the pseudocapsule, the myometrium, just disattaching the end of the myoma, and it's free. And you can choose whether to leave this small piece inside or take it out. He is going to take it out with a grasper. And from here, we go to another technique. It's an enucleation of the fibroid, the same that you perform during laparoscopy or during open myomectomy, but in this case, in office hysteroscopy. Look at this small fibroid, maybe it's 8 millimeters, 7 millimeters. It's a small G2 fibroid. So you cut around the fibroid like a crown that limits the fibroid. And then the moment you cut its crown around, you go there to find this cleavage plane. I told you about it before, the pseudocapsule. And then you find it, and what you do is disattach the myoma from the pseudocapsule without damaging the myometrium below. And look how the myoma is coming. It was almost all the myoma inside the wall, and it's coming out when you disattach it. This is in office without anesthesia. And when you try to start, you must start always with small myomas. Never try to start with a big one. It's difficult. But if you go from small to big, it's an easy way to learn. And then you take the grasper, and it's free. You take out the small myoma. This second myoma, it's a little bit bigger, and we cut around it with the laser. And now in a moment, you will see that the laser doesn't only cut like you see here in a very smooth way and painless way, but also coagulates the blood vessels. Now, in this image, you see the blood vessels here. I even not touch them, and they're already coagulated. So that's one of the characteristics of the diode laser in this wavelength. And the moment you cut the crown, you look for the cleavage plane. You look for this pseudocapsule. Look, it's not here, but now it goes in. So this is the plane, and then you do the dissection like in laparoscopy. Look, and you disattach the myoma. That's the way, the natural way to do this kind of surgery, to disattach the whole myoma. And I think there is another small video to perform also an enucleation with what we call the cold loop. And this is why I performed by the Gubini mini rossettoscope, G1 myoma. And the cold loop, it's a strong tool. Look, this is the cold loop. And you just pull the myoma out from his intramural area. Just pull it out until you disattach the myoma. It's an enucleation, like in laparoscopy. At laparoscopy, you pull also, and you disattach it from around. The same in this case. So you saw many techniques, different techniques. So my best advices for you, with this I finish, is first, as first steps, try hysteroscopy only. Just diagnostic hysteroscopy. Wait with the surgery of the uterine cavity. You start doing diagnostic. Then choose your first patient wisely. Don't start with a nulliparous postmenopausal woman. You choose a multiparous young woman, and it will be very easy. And with time, you can go to more difficult cases. And then don't start with the best setup for surgery. You don't need it. Just get a low cost with good quality setup, and you can start doing office diagnostic hysteroscopy. Learn to walk, just start walking, and then learn to run. You will run. That's all, friends. Thank you for listening. And as Einstein saying, and once you stop learning, you start to die. So don't stop learning. Thank you very much.
Thank you, sir. That was a wonderful presentation with so much of clarity on how to do office hysteroscopy. I think, as you said, we are also scared initially whether to do office hysteroscopy because we are so used to conventional hysteroscopy. And then, as you said, we have to crawl, walk, and then run in office hysteroscopy. So thanks again. And we'll move on to the next speaker. May I invite Dr. Jose Corugno for the next lecture? I'll just share the screen. So we'll take questions in the end. We have a lot of questions coming. So we'll take questions in the end. And talking about Dr. Jose Corugno, sir, hearty welcome to you. He's from Florida University. He has finished his fellowship in minimally invasive surgery. He's also a robotic and a laparoscopic surgeon. And he has joined currently the functions as the director of minimally invasive surgery. He is a part of the global community of hysteroscopy, the board member. So over to you, sir. Can we look at sir first? Because even yesterday in the trial, I couldn't meet you, sir. So I would like to see you. Can you stop this screen sharing? Sir, we would like to see you.
Tony?
Hello, can you hear
me? Full screen before you share your presentation.
Yeah, one second. I'll go in a second. Yes, can you hear me now? Can you see the slides?
Yeah.
Can you see the slides?
Yes. No, we would like to see you first, full screen.
We don't see your face.
Oh, hold on.
Stop sharing your screen, Tony.
Yeah.
He's a shy guy.
Hold on. What do you mean you don't see my face?
Can you stop sharing?
You mean stop sharing?
Yeah.
Okay.
Yeah.
How about now?
There you are.
Okay.
They wanted to see your face.
Oh, okay. I see my face first. Okay. Yeah. Hi. Hello. Thank you so much. It's a great pleasure to be here. It's the first time that somebody actually liked my face better than my presentation. So it's an honor. Thank you so much. You know, it's a problem because now I can't get my hair cut because there is no barber. They're still closed. So it's a problem. But thank you so much. It's a great pleasure to be here with you. It's an honor. As I said, you say, we like this webinar better when we go visit your country and we taste your delicious food. But unfortunately, I have to stay here in the US and eat my cheeseburger until the lockdown gets over. So
yeah, when everything gets fine, I think you are invited to India, sir. We would love to.
Oh my God, I love Indian food. I'll tell you that. So with that, let me start sharing again. Okay, can you see the presentation now?
Yes.
Okay, good, thanks. Okay, so I was invited to talk about how to choose the right tool. And because that's the most important thing. When you choose your tool that you're gonna deal with pathology with, you're setting yourself up for succeed. And I would like to start saying that I have no financial conflict. I'll be naming some products here, but again, I have no financial attached to any of the products that I'll be naming. And we have gone a really, really long way, right? Since when Pantaleone did that first operative hysteroscopy, that he removed that polyp in the postmenopausal patient and got all excited. And now we're here, right? Technology has brought us to the point that, as Sergio showed a couple of devices now, that all you need to do hysteroscopy is your cell phone. You just attach a disposable device to your cell phone and that's it. You're ready to do hysteroscopy. Like here, and then you know, all this is disposable. You bring your cell phone, and this is it. This is your setup. You're ready to do hysteroscopy. So it's a myth that you need, you know, a towel, a big investment, a fluid management system, and all that. Technology has gone so far that now it's extremely easy to perform a basic in-office hysteroscopy. But the thing is, you really need to choose wisely the tools that you're going to use. And again, no financial conflicts. So what dictates how you choose the device that you're going to perform the procedure with? Well, first, if the objective of the procedure, then the settings where you're performing the procedure, then the scope of your practice, the pathology, and why not say cost and reimbursement. At the end of the day, this is what we do for a living, and there are some limitations, financial limitations, and there could be procedures that you'll actually lose money if you choose one approach versus the other. So starting for the objective of the procedure. So what is that you want to do? Is this a diagnostic hysteroscopy that you're doing just because you need to get diagnosis? You're suspecting the patient has endometrial cancer and you just want tissue diagnosis to then perform another procedure, in this case, a hysterectomy or whatever the procedure will be. So your idea is only diagnosing the pathology? Or you actually want to treat the patient in just one sitting, and it's the approach that we are pushing now for, is this so-called see and treat, where the patient will come to your office, you're diagnosed there, but you're also planning to treat her condition just by performing a hysteroscopy. The other important thing is obviously the setting. And if you're a handsome guy like the one here in this picture, in an office setting, so you have some limitation because your patient is awake, there is a time limit, there's some limit as far as the complexity of the pathology that you can treat in an office setting, versus if you're in the OR, where the patient is under anesthesia, there is no pain, you have all the time of the world, you can dilate, and you can use larger instruments. So the setting also will definitely be an important factor to consider at the time of choosing the instruments that you're gonna use. But the most important thing is this, it's the scope of practice. And as Sergio already alluded, unfortunately for hysteroscopy, although things are changing now, since the Global Congress of Hysteroscopy came up, but it's only a minority. It's like little bit of people that's above the water there. That's the amount of gynecologists that are currently incorporating hysteroscopy into their clinical practice. So it's probably 10, 15%. The vast majority of gynecologists still haven't incorporated hysteroscopy into their practice. But if you're watching this webinar, chances are you're here. You're in the top area outside the water. But this is the reality. Most of the gynecologists, now, if you were lucky, they will diagnose with the hysteroscope, remove the hysteroscope, get that curette or the ring forceps or the polyp forceps and perform whatever procedure needs to be performed. There is a 25% of current gynecologists who are actually embracing hysteroscopy somehow, either in an office setting or in the OR, and are performing the entire procedure hysteroscopically. And a little minority are the ones who are actually using resectoscope and performing complex hysteroscopic procedure. There are those that Sergio defined as intrauterine surgeons. But this is it. It's again, it's the scope of practice. You have to go by steps, right? But if you practice, if you're busy obstetrician who deliver 300 deliveries per year, and most of your patients that you see in your office are prenatal care, and then eventually you will do one or two hysteroscopies a month, that's your scope of practice. You don't really need to learn resectoscopy. septoscopy. You just should be honest to your patient. Just refer those patients out. And I define, and this is, I arbitrarily gave these numbers, but basically there's three type of hysteroscopies, right? We have the low volume hysteroscopies, is that gynecologist who has a heavy obstetric practice. Then they have the intermediate volume hysteroscopies. It's probably the physician. There is always a group of 3-4 physicians, right? And there is one who likes more gynecology, the other do more obstetrics. So that one that does gynecology a little bit more is probably an intermediate volume. And then there is the high volume expert hysteroscopists who will do nothing but hysteroscopy or limit their practice just to gynecologic endoscopy. And that's a totally different specialty, I will say. So those low volume hysteroscopies that do less than 10 hysteroscopies a month, to have disposables make perfect sense. You don't need the capital investment in front. These disposables are really, really cheap. There's many in the market. This is probably one of the first one that came out, right? The Endo-C. There is this base that you keep and recharge, and then you have this part which is totally disposable. And again, you don't need fluid management system. You don't need anything. All you need is this. And if you are a low volume hysteroscopist, there is no need for you to invest. This will give you the diagnosis that you need. You're not treating any intrauterine pathology. So probably this is possible to make perfect sense for you. The other side of the coin, though, is their quality of the but I will say start making sense to invest in a real solid hysteroscopy equipment. And when I said that, you probably all you need if you're starting is this. It's one set of a rigid scope. If you can choose the one that's the oval tip is best, in my opinion, and has a 1.5 French channel. With this, you'll be able to treat 90% of the intrauterine pathology the right way. And again, if you're intermediate, you're not an expert, you don't really need more than this. And 90% of your patient will be covered. All you need to do is refer out to a high volume surgeon, the other 10% of patients who will have a more complex pathology. Just a word about flexible scopes. I used this during fellowship. I really didn't like it. It's kind of okay because it's flexible, can go in relatively easy, but the image quality is poor and you cannot have a working channel. So I will say flexible scopes are better for other endoscopies like colonoscopies and upper endoscopies, but for hysteroscopy, I don't think the flexible scope has a role. And that's my personal opinion again. Regarding fluid management systems, yes, you can have a full fluid management system, but this is all you need. Or you need gravity. You really don't need a fluid management system if you're limiting yourself to small intrauterine pathology. And like everything, you know, the industry comes and they will come up with stuff that make your life easy. And now they basically sell the entire tower, including the fluid management system here that can be moved around from room to room if you have an office with 2-3 different rooms that you can perform procedures at. And again, this is very portable and easy to use, but it comes with a cost, right? Those things are expensive, but you can go as complex as you want. This could be your office. But this brings me to what I make my point is, now we're all trying to bring the patient out from the OR to the office, right? Everyone wants patients out of the OR. But I think we're making a mistake if we are bringing the OR to our office. It defeats the purpose. What they're doing here, yes, you're taking the patient out of the OR, but you're bringing the OR into your office. So this here, including an anesthesia machine here, and you're doing procedure under general anesthesia in your office. That's probably a wrong concept there. And then there is the expert gynecologist, right? The expert endoscopic surgeon, which is the intrauterine surgeons, like Dr. Haimovich always says. And what dictates which instrument the experts use is basically the pathology that they're facing. And I like to use this example because it's a real life example. We had a patient, the residents received at the clinic, and she had an ultrasound and showed a 9 by 8 centimeter submucous fibroid. And the residents got all excited and came to me, oh, we're going to do this hysteroscopic, right? It's submucous. I said, no, I mean, how are we going to do an 8 centimeter submucous fibroid hysteroscopically? Even that, you have to remember that the time that you take to remove pathology, it's exponentially higher, right? You don't take twice as much to remove a 4 centimeter fibroid than a 2 centimeter fibroid. It's exponentially that it goes. And here, Dr. Montevecchi gave me this slide that, well, as the volume goes up, right? As the diameter of the fibroid goes up, the volume goes exponentially up. So that's something that you need to consider. So what is the right approach? Should I approach this patient with this 8-9 centimeter submucous fibroid hysteroscopically, or it's laparoscopically that I have to go? And although some expert hysteroscopists might attempt to do this hysteroscopically, I have a better plan. And this was the plan that we did for that particular patient. But again, it's the level of comfort. I think that patient with when you start talking about above 4 or 5 centimeters, the hysteroscopy route, obviously, you have to take a case by case basis. But when we're talking about type 2 fibers or type 3, when you're talking about above 5-6 centimeters, in my opinion, those patients are better done from above. But again, all this technology comes with a cost, right? And the more complex the technology is, the higher the cost. And you have to take that into consideration, right? And talking about cost and about technology making our life easier, the morcellators, this is really a game changer because they allow to do intrauterine surgery in a way easier way. This is like the robotic technology for laparoscopy, in my opinion. It really decreased the learning curve of hysteroscopy. But again, it comes with a cost. But it's like a game. It's a video game, and as you go, it goes eating the pathology. It's fun. My residents love to do this. and you don't deal with chips, right? You don't deal with any of that. It goes relatively fast and easy. There is no there is with the morcellator, there is no risk of thermal injury. There is no energy use. The learning curve is really easy, and it's being embraced by many gynecologists. So should I use the resectoscope instead of the morcellator is the question. And the been a systematic review that proved that the morcellator, the chances of actually succeeding removing the pathology goes up, and the operative times went down. And there's another systematic review that concluded that using the morcellator, shorter procedure time, smaller fluid deficit, and lower chance of having an incomplete resection. So it totally makes sense to adopt the resectoscope into practice, that to the point that some experts are saying, should we totally abandon resectoscope and just use intrauterine morcellators? And, like everything, now you have to take the good things and the bad things. And the good thing is this: it's easy to use. You use normal saline, it's relatively safe. But the bad thing is there is some limit. There is some pathology that you just cannot address with using the morcellator. And this is the analogy that I use. The morcellator would be like a Toyota Corolla, and the resectoscope is an SUV, right? If this is your road, you're going doing like easy cases, pleasant cases, it's not a problem. You can use the morcellator. But if you're planning to embrace this route, then you definitely need a more powerful tool, right? Which would be the morcellator. So, but it's a matter of choice. Again, if you limit yourself, if this is all this is all the road that you're gonna go to, so you don't need to learn the skill to use the morcellator, and just the resectoscope, and then stick to the morcellator. But then if you're embracing the tough case, then you definitely need to be skilled with the resectoscope. I just want to use a word of caution here in retained product of conception, which is very commonly treated with resectoscope, with the morcellator. Careful, because this procedure could be bloody, and if it bleeds, and as you do it, and you encounter bleeding, and you're using the morcellator, there is no way you can coagulate the bleeder. So for retained product of conception, I will recommend still using the, see, it could be bloody. I recommend using the resectoscope. So many opportunities in the market. Remember, as we concentrate in treating patients, there is a group of people who are making business out of this. And these are the companies that are making billions out of medical technologies. And we need to be conscious of that. As they create more and more devices, the latest thing is this, the mini resectoscope, which allows you to use the all the capacity of the big SUV, the big resectoscope, and now you bring it in an office setting. And now this paper just came out a couple of days ago. This is the proof that the mini resectoscope is being better than the larger resectoscope, just because you don't need to dilate. So it's equally effective treating the pathology and pain, but it's no surgical time. There's no need for cervical dilation. There's less fluid absorption, less postoperative pain when you use the mini resectoscope, and it's great patient satisfaction. So my take-home message is, when you choose, you have to choose wisely. Not always the newest thing is better. Select your instruments based on the pathology. Become familiar with more than one instrument in case you need to change last minute. Always consider cost, and patient safety should always be your priority. As we concentrate in treating patients, technology will go hand by hand with us, making our life easier. But remember, at the end of the day, the patient is in our hand, and whatever we choose, we might change that patient's life forever. Thank you so much.
Thank you so much, sir. That was really good. And you
tissue removal systems, and they looked at the mean